So I was given a bit of a challenge in this topic, and I chose that I'll be a bit of a curmudgeon about this. So what is precision medicine? Precision medicine refers to the tailoring of medical treatment to the individual characteristics of each patient. It does not literally mean the creation of drugs or other devices that are unique to a patient, but rather the ability to classify individuals into subpopulations that differ in the susceptibility to a particular disease, in the biology and or prognosis of these diseases they may develop, or in their response to a specific treatment. Prevention or therapeutic interventions can then be concentrated on those who will or will not benefit, sparing expense and side effects to those who will not benefit. Put more bluntly, in the recent Precision Medicine Initiative, precision medicine is an emerging approach for disease prevention and treatment that takes into account people's individual variations in genes, environment, and lifestyle. So here's a perfect example of precision medicine. This is from a New England Journal article that was published online on June 3rd of this year, from a study of adjuvant chemotherapy guided by a 21 gene expression assay in breast cancer that demonstrated that in patients with breast cancer who were axillary node negative and who had a mid-range 21 gene recurrence score from this 21 gene array, that adjuvant endocrine therapy and chemoendocrine therapy had similar efficacy, so that these patients don't require chemotherapy. This is a radical finding and is an I think a paradigmatic representation of what we mean by precision medicine. So, there was an ADKey published recently, held a couple years ago. Dr. Kellum and Dr. Ronco authored the initial article in this, introducing precision renal replacement therapy. So is renal replacement therapy something that we can talk about precision medicine in? So here's how it was defined. Precision renal replacement therapy is the use of specific information about the patient to personalize the use of renal replacement therapy and the renal replacement therapy prescription to the individual patient. This information would include measures of solute load, fluid balance, residual kidney function. It might also include information on the inflammatory response, oxidative stress, even genetic makeup of the patient, and would definitely include hemodynamics, comorbidities, and consider the medications of the patient's needs. So the question is this really precision medicine? And I would argue that precision CRRT is not at the level of what we understand precision medicine to be in 2018. In fact, I do this graphically. Precision medicine illustrated here by a laser cutting a circuit board versus CRRT, which has the delicacy and precision of a jackhammer. So what is meant by precision CRRT? In this ADKey, we have a series of publications looking at various aspects of renal replacement therapy, and specifically CRRT, that try to take a precision approach. And what I would argue is that this approach is tailoring it to the patient, but not to the level of what we would consider precision medicine. So what are the recommendations? Acute renal replacement therapy should be considered when the metabolic and fluid demands exceed total kidney capacity. Okay? That sounds reasonable How do we measure it precisely? Demands for kidney function is determined by non-renal comorbidities and the severity of acute disease, solute and fluid burden. I don't think anyone would argue with that statement. And the demand capacity imbalance is dynamic and should be evaluated regularly. Well, that's fairly self-evident as well. They created this very nice cartoon illustrating demand and capacity, and I would argue that, in fact, by definition, acute kidney injury is a situation where capacity is acutely decreased. Demand does not decrease in proportion to it, so you have, by definition, an imbalance. That's why patients develop progressive azotemia, electrolyte disturbances, volume overload that are the hallmarks of the patient with acute kidney injury. And I don't think that this paradigm that's being described really tells us when we need to start. Another cartoon that they have showing this with the blue representing chronic disease. I believe the orange is acute disease, the green is volume, and then we have these lines of kidney function and various patterns. And demand and capacity imbalance, and demonstrating how this can be overcome by the superimposition of renal replacement therapy. Well, if it was that simple, we'd have no controversy then as to when to start. But we have controversy. We have recent studies, this from Zarbach and colleagues, the Elaine trial, suggesting that earlier start of renal replacement therapy is associated with better outcomes, versus the Akiki trial from Gaudry and colleagues that concluded the exact opposite, that there was no benefit to earlier start. And I'm not going to go through all the debate about the differences here. But if this question of precision timing were so simple and straightforward, if we could answer it, we wouldn't have this controversy. How about selection of modality? Do we have precision here? Selection of renal replacement therapy modality depends on the capability and availability of the technology, its inherent risks, and the current needs of the patient. Continuous types of renal replacement therapy are recommended in situations where shifts in fluid balance and metabolic fluctuations are poorly tolerated. Intermittent and prolonged intermittent types of renal replacement therapy have a role in situations where rehabilitation or mobilization is a priority, and fluid and metabolic fluctuations can be better tolerated. Transition of modalities should be considered if the demand capacity imbalance or treatment priorities have changed and can be better met by an alternative technique. That all sounds wonderful, and we have a figure here showing these differences. Continuous therapy with greater hemodynamic stability, but an increased risk of infections and greater immobilization. In the middle, the hybrid therapies, and on the right-hand side, intermittent therapy, where the rates of fluid correction are more rapid, but there's the increased risk of osmolar shifts, increasing risks of hypotension from these. But in fact, you can adjust the intermittent therapy treatment to mitigate those risks. And in fact, there is controversy as to how we deploy these modalities, when is the best time, and we have a lack of true precision in selecting between one and the other. How about dose? Dose we have more data on. CRRT dose identifies the amount of blood cleared of solute by unit of time, and I would argue that that's a rather limited definition of dose, but that was what was the statement from the ADKI group. Effluent flow is an acceptable surrogate prescribing dose. The clearance is dependent upon sieving coefficient of the representative solute. That's clearly the case. And the default CRRT dose should be 20 to 25 milliliters per kilogram per hour for representative small molecular weight solutes, with urea as the solute most commonly used to quantify dose. I'm certainly not going to disagree with that statement, since it is derived in large part from a study that I was responsible for. The prescribed dose is dynamic, with default dose can be modified according to patient demand and the response to iterative evaluation of quality measures. The prescribed dose should be evaluated at least once every 24 hours or more often according to patient needs. Dose delivery can be estimated as intensity or as time averaged delivery of dose, and it should be routinely assessed and modified based on iterative evaluation of quality measures. Dose delivery should be evaluated at least once every 24 hours according to patient needs. And I'm not going to disagree with any of those statements, but I don't think there's tremendous precision in this. I will agree CRRT dose should be dynamic and adapted to changes occurring in the acuity, physiology, and metabolic profile of the critically ill patient. Critically ill patients are heterogeneous, certainly, and vary widely in their demographics, chronic disease burden, case mix, and illness acuity. And various cartoons to illustrate this. This just shows the cycle of looking at the prescription, the quality measures of that prescription, the outcomes, and the delivery, with a feedback going from prescription, delivery, looking at the outcomes, adjusting based on quality measures, and feeding back on the prescribed dose. And precision CRRT dosing should be adapted to target specific solutes. And there's this lovely graph that they do of different patients and how they require fluctuating dose between the standard dose of 20 to 25 milliliters per kilogram per hour and a patient who requires increase, decrease, increase, and maybe another patient where a lower dose is necessary. Where are the data to support this approach, other than the fact that if you have a hypercatabolic patient who's hyperkalemic, you may need an increased dose of therapy to handle that acutely? Do we have data that says that a patient other than a patient who's recovering kidney function actually does better with a decreased dose of therapy? We don't have data to support that. While this is nice conceptually, we don't have the data to precisely guide our therapy in this fashion. The data we have, derived from the ATN study and the renal study, suggest 20 to 25 milliliters per kilogram per hour effluent flow is at least as good as a higher dose of therapy. It actually doesn't tell us. Neither of these studies tell us where the floor is. They just tell us that in the average patient, you don't need a markedly higher dose of therapy. Well, what about volume management? Dr. Murugan's going to be talking about this next, but the recommendations here from the manuscript that he authored says that clinicians must continuously assess fluid balance and set targets for this variable. These targets should be used to inform decision-making on timing and methods for fluid strategies, whether they are pharmacologic, i.e. diuretics, or mechanical, i.e. renal replacement therapy. And the goals of care should define the utilization of solutions in fluid balance. Achieving overall fluid goals requires characterization of operating characteristics of CRRT, flexibility of changing plasma composition and volume status independently can be tailored to meet the needs of the individual patient. Recognizing the importance of modifying either circuit integrity or plasma composition or fluid balance will influence the other components. And it's recommended that the patient's hemodynamic response to fluids removal be monitored closely and fluid removal rates be adjusted to maintain hemodynamic stability. And this just shows that in a cartoon that the more closely you monitor, the more closely you can make adjustments to prevent adverse events and achieve the therapy that you want. This, I think, is fairly intuitive. I wouldn't call it precise. Given the difficulties in predicting how an individual may respond to mechanical fluid removal, a reasonable approach is to start with a low rate of removal and slowly increase this to the maximally tolerated rate while monitoring hemodynamic response and avoiding hypotension and decreases in end organ perfusion. The patient's response to net fluid removal should be assessed frequently. I would refer to this as common sense, but relatively imprecise. Renal replacement therapy should be discontinued if kidney function is recovered, certainly, to the level to reduce the demand capacity imbalance to acceptable levels. To determine sustained recovery of kidney function, they recommend monitoring urine output and serum creatinine. And for patients requiring multiple types of organ support, decisions about withdrawing renal replacement therapy need to be considered together with those other therapies. And then there's a discussion of technology in CRRT. Then this may be the area where where this approaches a degree of precision with the idea of having feedback loops that could potentially automate some of the decision making. What I take from this is not that we are in a new era of precision renal replacement therapy. Renal replacement therapy remains a rather blunt tool in our armamentarium. It's still an important tool. Hammers are important tools, but they're blunt tools. And the concept of paying attention to the patient is nothing new. I certainly didn't develop that concept, but I'll point out that in my editorial about the renal trial, my conclusion was that it should not be forgotten that patient care needs to be individualized. More intensive therapy may be required for the treatment of hyperkalemia, metabolic acidosis, or extreme hypercatabolism, and that the true adequacy of renal replacement therapy is defined by much more than the clearance of small solutes. So, precision renal replacement therapy, it's a dream, but we're not there. It remains a blunt, imprecise treatment in 2018. That is not to say that the goals set forth in the ADKI of individualized treatment are not appropriate. And renal replacement therapy certainly needs to be individualized to the patient who is before you in each room. AKI is certainly dynamic, and therefore the prescription of renal replacement therapy needs to be dynamic, but we don't have the precise tools that we really need to strive for to be able to truly optimize therapy. And the parameters for individualization of many aspects of renal replacement therapy remain poorly defined as of 2018. So my conclusion is that precision renal replacement therapy is a dream that we have not yet reached. And we need to move forward to be able to better individualize care for each patient, but we're not there yet, and this certainly isn't precision medicine at this point. So with that, I thank you, and I think we'll move on for our next speaker.